interest of time. Good afternoon, everyone. We might make a start in the interest of time because there is a back-to-back meeting in this theatre and we do need to be out by 2 p.m. Just before we start our formal presentation today from with our guest speaker, we would like to acknowledge the traditional owners of the land in which this event is taking place, the land of the Wurundjeri people of the Kulin Nation, and pay respect to their elders and families past and present. For those that don't know me, my name is Heather Thorne. I'm the National Manager of KConfab and I'm based in the Research Department on the 11th floor of the Research Department here at Peter Mac. Cohorts at Peter Mac are very strong with about 20 years of history behind them. So the topic for us today is very pertinent and we very much look forward to hearing the updates. I'd just like to also point out that there's some other great speakers coming up in the next couple of months. You can go to the VCCC website to register your interest to be involved. And of course the VCCC, for you people here today or who may be online, the Victorian Comprehensive Cancer Centre is a powerful alliance of 10 successful Victorian organisations committed to cancer control. Its role is to coordinate and the collaboration between its member organisations and to develop a strategic program of work that integrates research, education and clinical care to maximise patient outcomes in a cost-effective manner. So, it is my pleasure to introduce to you today Dr. Megan Proctor. As we know, biobanks are large repositories of biological samples often linked to health data collected over a long period of time. Because people who contribute samples and data to biobanks are unlikely to know what these donations will be used for, except in a very general sense, it is difficult to ensure meaningful informed consent and ongoing communication between participants and researchers. Today we'll hear from Megan, a lawyer and researcher interested in people's experiences of healthcare and health research, specifically data privacy and consent in the context of new technology and, dare I say, recent media events. Her presentation will outline a dynamic consent tool and report on its application in diverse international research. This will include an overview of a current project involving Helix, both at Oxford in the UK and where Megan's based at the University of Melbourne, to embed dynamic consent in Australia genomics research. So please join me in welcoming Megan to the podium.
Messed it up already. All right, thank you so much for that warm welcome, Heather. And thanks for the VCCC for the opportunity to present today. It's a privilege to be here today to speak with you about informed consent, dynamic consent, and our research which looks at the social and legal issues in new and innovative health technologies. I also want to acknowledge the traditional owners of the land on which we meet today. So today provides a great opportunity for me to introduce our research team, Helix at Melbourne, which is based at Melbourne Law School, which has a lot to offer the research community here at the VCCC, as well as across the Melbourne Biomedical Precinct. I'm going to speak today about our research into informed consent as a legal and ethical basis for data collection and use, specifically in the context of biobanking and genomic research. I'll introduce a consent model which our director Jane Kay and my colleague Harriet Tier have led, called dynamic consent. And this offers a new way of approaching the consent task, using a web-based tool that enhances people's ability to exercise real choice over time about what happens to their samples and data. I'll outline a pilot evaluation of the tool here in Melbourne, led by the Australian Genomics Health Alliance, and finally offer some thoughts about where to from here. I'm very pleased that Harriet here is also here today and will be happy to join me in answering any questions about the projects she's been involved in after this presentation. So first I want to introduce our group because we're all new. Helix is a research team focusing on health law and emerging technologies based at the Melbourne University Law School. It's an offshoot of a team of the same name based at the University of Oxford, which Professor Jane Kay established in 2009. The local team has been set up only over the past 12 months, and we've got some staff who are joining us from Oxford just for this establishment phase. So we're a multidisciplinary group comprising lawyers and social scientists based at Melbourne Law School, but as I said, with an outward-looking approach across the university and the biomedical precinct. Our focus is on how the development and use of innovative health technologies can be accommodated within existing legal and regulatory frameworks and how these frameworks might need to adapt. So we're interested in systems that provide for social inclusion, the empowerment of research participants, and that enhance the public good. And you can see some of our current projects on the screen. We work with colleagues from other university faculties and departments, as well as the Australian Genomics Health Alliance and others interstate and overseas. So today I'm here to talk about informed consent from a research perspective, and it's here that the multidisciplinary nature of our team's experience really comes into its own. Before I became a lawyer, for many years I was based at La Trobe University as a managing editor with the Cochrane Collaboration, publishing systematic reviews of randomised trials, primarily in the area of health communication and consumer participation. I was fortunate to become embedded in several of these reviews as a co-author, and one of them assessed the effects of multimedia interventions for improving informed consent for people who were thinking about going into a clinical trial. But in addition to that specific review, because I was constantly assessing the methodological quality of randomised trials through a consumer-centric lens, I developed a strong interest in people's engagement in research, their understanding of it, their informed decision-making about taking part. And so I was very pleased to bring along that experience when I joined Helix last year. So many of you are here today because you're researchers or you're interested in the research process. And so I think it's going to be well known to you why we do informed consent. That it involves setting out the details of the research, including its risks and benefits, so that people can decide whether they want to take part. It has been a fundamental principle in modern medical ethics ever since the Nuremberg trials, and it's designed to honour personal autonomy and to avoid any sense of coercion. Probably you are also familiar with some of the issues or debates around informed consent for research. And if you've ever been involved in developing a consent form or in reading one as a participant, you'll know that they're long and complex, but despite our best efforts to write them in plain language, there are terms and concepts in them that are really hard for people to understand. There's a particular difficulty in trying to convey that information to people from culturally and linguistically diverse backgrounds, people who have lower levels of literacy, and people of different ages. Research has shown that consent information is very often misunderstood by participants, and that the knowledge they might manage to gain is quickly lost over time. There's also concern that participants don't always feel they're making a decision, that they really can say no or ask for more information or more time to reflect on their choice. Some research indicates that, especially when people are signing up to research at a time when they are also receiving clinical care, maybe they've just received bad news about their health or are in a stressful situation or environment, that they often don't recall having consented to research at all. The form becomes just another piece of paper. Let's just sign it and get on with things. So in light of these concerns, there's been substantial attention to and investment in attempts to improve informed consent. And here I'm going to talk about informed consent for both research and for treatment, because work that's being done to improve informed consent crosses over both these streams. Some of the things that have been tried include simplified language, the addition of pictures or an altered layout, things to make the form more readable, much the same techniques that people use in health education research. Researchers have tried giving extra information, either by expanding the written material or adding an oral description as well. They've also tried using computer-based technologies in different ways. And informed consent has in the literature become considered as an intervention in its own right, and these enhanced modes of consent have therefore been evaluated in clinical trials which have been brought together into systematic reviews. So if we're considering enhanced informed consent as a discrete intervention, we can also evaluate its effects on a range of outcomes. While there have been some recent attempts to define a composite outcome measure, something like truly informed consent, especially by Paul Kinnersley and by Julia Wade, these haven't been widely adopted in the literature. So most studies in the field focus on knowledge and understanding, satisfaction with the information, the rate of participation and the rate of withdrawal from research, people's levels of anxiety or stress, their satisfaction with the decision, their trust in the research, and then some outcomes that reflect on the clinician or the researcher experience, so how satisfied they are with the process, how easy it is to use, how long it takes to administer. At present, a team led by Katie Gillies in Aberdeen is undertaking a large Delphi process to identify a set of core outcome measures for informed consent research, and I'm very much looking forward to its publication in the next 12 months or so that future trials in this area can measure outcomes in a consistent way that facilitates data synthesis. So far, systematic reviews of randomised trials of enhanced consent interventions have found a good deal of heterogeneity in the interventions, the study designs, and the outcomes that have been assessed. I was a co-author of Annie Sinnott and colleagues' 2014 Cochrane review of audiovisual interventions for improving informed consent for research. We identified 16 trials in that review, mostly based in the US. The review found that the effects of audiovisual consent interventions were still largely unclear, and this finding was consistent with the other main reviews in this area by Flory, Cohn and Nishimura. They found a lack of high-quality research, small or no improvements in knowledge and understanding of the parent study, mixed effects on satisfaction, and no effect on participation. So the last result is not necessarily a bad thing. One thing we don't want to see is a reduction in participation as a result of better quality consent processes, and researchers do often have concerns that this will happen. There are two other important systematic reviews in this field that I want to highlight. One about decision making for research, the first one, and the other about consent interventions for treatment. So the first, Katie Gillies' review of decision aids, found only 2 studies and insufficient evidence to draw any conclusions. However, when we look at the review of enhanced informed consent interventions for treatment, specifically for surgery and other invasive procedures, we find a very large number of randomised trials, comprising over 9,000 patients altogether, with clear results that included improved knowledge that persisted well after the treatment episode, greater satisfaction with decision making, reduced decisional conflict, and no change in anxiety or with satisfaction with the consent process. So what does this mean? Well, I take from this that it is possible to improve informed consent processes for research because there is high quality, robust evidence that it can be done in the context of consent for treatment. There is certainly scope for experimenting with new approaches in the context of research, and new technologies can help. More on that in a moment. So in summary, truly informed consent for research is hard. Researchers are doing their best, but the tools at their disposal have limitations. Because we can conceptualise and evaluate informed consent as an intervention, we have learned that strategies to improve it can have some benefit. In the field of informed consent for research, so far study numbers are small, results have been mixed, and more research is sorely needed. However, in enhanced informed consent for treatment, there is robust evidence that efforts to improve the research, to improve the process have benefit. The main message, I think, is that there is an opportunity here. So far, I've been focusing on informed consent for traditional forms of research, specifically the clinical trial. People sign up, do the study, the process finishes. They have a clear, well-defined scope and an end point. But what happens when we throw innovative health research tools and structures, such as biobanks and genomics-based research, into the mix? So as you know, over the past 20 years, there's been substantial investment into biobanks as a tool for disease-oriented research or for work on population health, ranging in scope up to biobanks for entire countries. They comprise biological samples of different types, often with associated health and demographic data, which are available to researchers who can apply to withdraw the samples and data they need for their work. There was a lot of excitement about and investment into biobanks in the first decade of the 20th century, but they have also faced challenges. They're expensive, both to collect and to maintain, and some are not used to maximum effect. The regulatory context that they operate in is complex, fragmented, and changing. There are many examples of Australian biobanks that are positively flourishing and have formed the basis for research projects offering profound benefits to the health and well-being of Australians. Many of these, it is worth pointing out, are already very large infrastructures containing samples and participants numbering in the tens of thousands. And as you would know, BCCC is a partner in a number of biobanks, including some of those listed here. Also part of the context for informed consent that I'm talking about today is genomics research, which biobanks often support. There has been major progress across Australia on projects that will embed whole genome sequencing into clinical care. Some examples of these are on the screen. The Australian Genomics Health Alliance and its Melbourne counterpart are leading the way. Like biobanks themselves, genomics research projects like these are marked by their large scale, being ambitious, often nationwide endeavours. From the participant perspective, there are similarities in the experience between biobanks and genomics-based research, which is why my team is interested in enhancing informed consent for application in both contexts. Some of the features of biobanking and genomics research that make consent a real challenge are, particularly with biobanking, people are donating samples for unknown future use. Those samples might be shared across different organisations with different legal structures, for instance, between a public institution and a for-profit company. They might move across state boundaries or national boundaries. Both biobanks and genomics research raise the challenge of what to do about additional and incidental findings. If it is desirable that these are communicated back, do the participants want to know about them? And if so, how? There might be a need to recontact participants, for instance, to collect updated health or lifestyle data that goes along with each sample. Findings of research that is conducted through biobanks or on genomic samples and data might have implications for family members and might also benefit from the linkage of records of family members. And yet consent is an individualised process. Finally, the legal framework is also challenging. Samples and data are often treated differently at law, with the former covered by human tissue legislation and the latter by data protection law. Legal requirements for informed consent are also changing in various ways, for instance in Europe with the introduction of the General Data Protection Regulation. These reasons are the basis for an approach to consent in biobanking which is now common, called broad consent, where a person is asked to give broad consent to a wide range of possible future uses of their samples and data. Focus groups conducted with medical researchers in 2012 identified that they often go for an even broader consent than that is usually discussed in the literature. Many felt it was the only solution to avoid going back through the cumbersome ethics process over again. Broad consent has been endorsed by the World Medical Association and the OECD, but it remains problematic from an ethical and legal perspective. It's hard to claim that consent to unknown future uses of the samples is truly informed in any meaningful sense. A possible solution is found in work that's been led by our team called dynamic consent. So dynamic consent refers to an approach to consent that enables people to make decisions, to review and change them over time. It's based on an electronic record of consent decisions, which are granular. So essentially it breaks the information that was on the large consent form down into much smaller chunks and asks participants whether they agree or disagree to each one. The dynamic consent tool establishes a communication channel with participants for the life of the project, or for potentially for biobanks and large longitudinal studies without any end in view. Because it is online and interactive, a dynamic consent platform can provide people with updates on what use their samples and data are put to. And it can incorporate different media to enhance participants' knowledge and understanding, things like videos, audio, animation, or interactive diagrams. Dynamic consent has many benefits. It puts participants at the centre of decision-making about their participation, not just at the start of a project, but for its whole duration. It enables ongoing two-way communication between participants and the research team. And importantly, from a legal perspective, the system captures this communication, enabling a secure single repository of communication and consent choices, providing a robust audit trail. Dynamic consent enables people to review their consent decisions at home after they have signed up in the research setting, which is often a clinic. This is particularly important since research has often shown that the lines between clinic and research are becoming more blurred. And as I mentioned earlier, people often can't recall the details of their consent or even that they decided to consent at all. So giving people the opportunity to revisit and reflect on their choices once they've left the clinic is really important. As I mentioned, information can be offered via the dynamic consent platform using diverse media with links to other websites, unlike traditional consent, which assumes that all participants must be given strictly the same information. This enables people to be more engaged in the research and to learn more about it to the extent that they wish. So the dynamic consent platform is not intended, at least at this stage, to be a replacement for face-to-face encounters, but it provides support for communication in between those encounters. And finally, it supports decision-making that can cross those boundaries between research and clinical care in a transparent way. So I'm going to talk about two examples from Europe where the dynamic consent approach has been applied and some of our learnings from those projects before outlining a new evaluation of dynamic consent coming out of Melbourne. So the first project is RUDY. RUDY is a study based at the University of Oxford on rare and undiagnosed diseases of the bones, joints and blood vessels, although I learned just last week that RUDY 2 has been announced, expanding the research to all rare diseases. RUDY is a 5-year prospective cohort study. It involves a large network of participants who provide information about their experience of their disease. There are over 850 people enrolled to date. They provide information about their symptoms and treatment and can also consent for the study to retain tissue samples that might be removed in the future as part of their clinical care. There are sub-studies within the main project in which it is planned that participants can also provide other samples. The project is strongly driven by patient groups, and so a dynamic consent approach is seen as a particularly good fit because of the opportunities it provides in terms of ongoing communication and engagement. So this is what RUDY looks like. You can look at it online at rudystudy.org. And I know this is a little small, but this is what a personal profile looks like for people who have signed up to the project. So consent is just one of the parts of the system. You can see down the bottom. You can see that the platform provides a detailed personal profile, including the sub-studies that are available for participation. And people can use it to record details of their own clinical care, their diagnostic history, their treating practitioners, and so on. So dynamic consent is contained in that little section down the bottom, which when you go to it, you can see that the elements of a traditional consent form have been split into various parts, and people can make granular choices about things like providing personal health information via the website for use by researchers, about data linkage, about choices to participate in the sub-studies. This clinical network will have a biobank embedded in it, so dynamic consent options enable people to say whether they want their data and samples to be shared beyond the clinical research team. In all cases, consent choices can be turned on and off easily just by changing the tick to a cross or otherwise, and people can log back on and see what they selected. In this system, researchers can also post lay summaries of abstracts and papers on the profile page of every participant who's contributed data or samples, so people can see very clearly what value their contribution has had. As I mentioned, Harriet Tier from our team has been working with the Rudy project for some time, and it's an exciting example of a dynamic consent tool embedded in research that has a very high degree of participant involvement over an extended period of time. Another example of dynamic consent is in an Italian study called CRIS, which is an acronym, beg your pardon, for Cooperative Health Research in South-Tyrol. This project commenced in 2011, collecting blood and urine samples and health and lifestyle data to illuminate the interaction between genetic, lifestyle and environmental factors in the development of a range of common diseases. Because this study is planned to run for 25 years, the principle of recontacting participants is really fundamental. The project did not initially involve dynamic consent, but introduced it a little way along in order to improve the ability to recruit and to recontact participants. Research conducted into the consent tool as part of the CRIS study found that the tool had some unanticipated benefits. While the intention was not to replace face-to-face contact, putting some of the material online meant that staff time needed for recruitment was reduced substantially. It also made it easier to ensure that all participants were receiving the same core set of information, as well as to collect data from whole families. And finally, it is seen as enhancing project governance, making it easier to ensure compliance with legal and ethical requirements, which is certainly bound to change over the long life of this project. Dynamic consent has not been without its critics. Common concerns expressed, particularly when the concept was first developed several years ago, included things like, what if giving people a better way to exercise their choice means that they withdraw? That will compromise our data set. It might cost more money to set up a tool like this. Is it worth it? Not everyone is comfortable using computers. Are we excluding certain patient groups? Unfortunately, there's still not enough evidence to say much about these concerns one way or the other. Generally, we think that giving people control over their data is a positive step. But anecdotal evidence from projects implementing dynamic consent so far suggests that the concerns may be unwarranted, and that over the past 5 years or so, an increasing reluctance to rely on broad consent has seen a greater level of comfort with the dynamic consent approach. But our team is really keen, particularly in the context of a need for more and better evidence about the effects of enhanced informed consent interventions that I described earlier, to see dynamic consent tested in controlled studies using validated outcome measures. Consequently, we're super excited to be involved in a pilot project involving 2 of the flagship projects under the Australian Genomics Health Alliance umbrella. As far as we know, this constitutes the first empirical evaluation of dynamic consent against a control group anywhere in the world. We're supporting AGHA flagships to offer a web-based portal that includes dynamic consent for half of their participants in projects embedded in clinical care that offer genomic analysis in interstitial lung disease in children called Children's and end-stage kidney disease, the project called KidGen. The portal will offer information about the research projects and granular choices to participants about their involvement, which they can revisit at any time. Our research question is, do more choices and control over participation result in an improved patient experience? So this study design is a randomised trial of dynamic consent that's bolted onto existing evaluations of people's experiences of the genomic research. and we're testing dynamic consent against a standard paper-based consent arm. Drawing on the outcomes list I outlined earlier, derived from high-quality systematic reviews, we identified a small set of important outcomes with validated measures, namely knowledge and understanding of the project, overall satisfaction, decisional regret, trust in the research, and rates of participation and withdrawal. We are also gathering metrics from the website in the dynamic consent arm only, such as the pages that people most commonly visit, how long they spend on them, and the point at which they exit the site. We look forward to sharing the results of this pilot study with you. Importantly, we also see it as contributing to the wider research picture by gathering robust data on the effectiveness of efforts to improve the informed consent experience. Finally, I wanted to mention a small project, a pilot project based at Melbourne Law School this year. We're delighted to be working with Sharon Hubner on a piece of research examining the cultural and legal requirements for informed consent for Indigenous communities in Australia for access to historical collections of genetic material. So an example of such a collection is the National Centre for Indigenous Genomics collection held at ANU, where samples and data collected from communities all over the top end were gathered in the 1960s and 70s, and those samples and data are still held there. This project will consider whether dynamic consent might offer a way of re-engaging with communities to essentially retrofit a consent model that meets the highest current ethical and legal standards. We're interested in seeing whether it might be possible for dynamic consent to be used in a way that provides both for individual and for family or group-based consent. We've got a lot more work to do, but we see this as a very interesting and promising trajectory for dynamic consent research in Australia. So in summary, I've asked whether we can do a better job of consent for research, particularly in the challenging context of biobanking and genomic research. I think the answer is definitely yes, we can. And in doing so, we can empower and engage with participants, help ensure that research is of a high methodological quality, and make researchers' jobs easier too. Dynamic consent is a distinctive approach in which consent is effectively ongoing, like the research itself. It allows people to review and change their decision if they wish, and facilitates ongoing two-way communication between researchers and participants. It meets the highest ethical and legal standards in a changeable landscape. We're really excited that the AGHA flagships are offering the opportunity, which we think is unique, for empirical evaluation of this tool, not least because the outcome data can feed into future quality improvement. And we certainly welcome approaches from others who may be interested in discussing the application of a dynamic consent approach to their own projects. Finally, I just want to acknowledge a few people, and particularly the team at Helix at Melbourne, Jane Kay, Harriet Tier, Jessica Bell, Mark Taylor, Carolyn Johnson, Sharon Hubner, as well as obviously the team at Oxford, which led a great deal of this research. And particularly the Australian Genomics Health Alliance flagship and flagships and the Dynamic Consent Working Group. Thank you.
Good. Thank you very much, Megan, for a very informative presentation. Just as a general comment, our cohorts here at VCCC have published on the fact that the Australian population, because the cohorts here do work nationally, are very proactive and very trusting and very keen to be involved in research projects. So certainly with your dynamic consent, it would be wonderful if more people can become engaged and feel that they have ownership in the research project and the management of their data. So congratulations in coming up with this scheme. I guess I can only say from Kate Confac's point of view, we have many of the younger generation who are very keen to be involved with electronic modes of communication. But you know, we still need that flexibility. Some of the older generation still do like post, telephone and face-to-face. So I think we just need to be aware. Maybe you could also comment, one of the biggest struggles for the Biobanks and cohort is because we do work at many different sites, not just even statewide but nationally, the different legislation, the different requirements between each state. We do get there, but I can't tell you the hurdles that we all manage logistically to get a project up and running. Are you speaking at a national level with the different state legislation, Department of Justice, to perhaps streamline this dynamic consent a little bit more to make it easier for large-scale national projects?
I think that's probably a bigger undertaking than our team can do, but certainly it's you know, it's a concern not just with this kind of research, but across the board about the state-based nature of regulation. I think one appealing feature of dynamic consent is that it can, you know, you could develop a platform that could essentially adhere to each state's requirements. Yeah.
It would be nice if we had a national agreed set of principles. So now open to the audience. Are there any questions or comments?
I'm just curious as to, in any 1 year, how many people complain about informed consent? Or, you know, the point was made that people are very trusting. Do you get feedback to say they're very happy about informed consent from people taking part in studies? Or is this assumed need to do it better and not necessarily driven by people who have taken part in a study and not being happy about it?
That's a really interesting point, thank you. I think the development of the tool is driven by research that shows that people often don't recall that they consented more than that they expressed unhappiness with having consented per se. So I don't know if my colleague Harriet is here and would mind joining me to speak about that any further.
So there is a fair amount of literature. There is a fair amount of literature talking that has specifically asked participants of their experience of the informed consent process, and depending on what you ask them within that research depends on how they are supported. So if you ask them, was broad consent okay, they will potentially say, yes, it was fine, and we were happy with that. One thing that's been interesting with the focus groups that we've actually done with participants, so the consent question came up from a legal perspective in terms of the informed consent process, and is it truly informed if you don't know what's going to happen later on. When we've then taken that to participants and talked to them, actually the thing that they've really appreciated with the dynamic consent approach is the opportunity to know what's happening. And actually there's an awful lot of literature across different types of research. So people don't know whether it's successful, they don't know what happened, they never heard afterwards. And that's potentially an issue where we're thinking about data protection, particularly from a legal point of view, but just from a general societal involvement in research point of view, there is benefit and value potentially from people having a greater understanding of what they're contributing to. And we kind of hope this will lend itself to that, but certainly the participants we've spoken to have been very keen on that side of things. What we now need to figure out and what this will hopefully do in this study that Megan has described is actually look at how that then objectively feeds into the patient experience. And if it's a better experience, potentially that's a positive thing from the research, but also encouraging people to take part more in the future.
Mark Rosenthal, Medical College, so I've consented hundreds and hundreds of patients for clinical trials. And I think the Dynamic Consent Project had programs to review, but I'm disappointed about how little information there is about consenting for clinical trials here. Really said there's not much in the way of information. And I think the challenge might be to understand consent for clinical trials better and work out a mechanism by which we can improve. So, we have a 25-page consent form. It's difficult to read, complex. We have a doctor, an investigator like myself, trying to sell the trial, genuinely believe in the trial. That's an important part of it. We have patients, some of whom want absolute detail and ask probing questions about the trial. Others say, how do I sign? And not even want to read the consent. So there's a great challenge to develop a properly informed consent program for clinical trials. And I wonder how you see that challenge and how you see that might move forward in the next 5 to 10 years.
Interesting question. I guess, I mean, a tool such as dynamic consent or a web-based approach to consent can solve some of those problems, but not all of them. So it can solve things like giving people the access to the amount of information that they prefer, a more minimal set of information, and here I sign here, or links to other high quality material, as far as they want to go down the rabbit hole. So I think that's whether it's a dynamic consent approach that records those decisions that they can revisit later or not, whether it's just a web-based document essentially with links, that can help. But it doesn't solve the problem of people who aren't comfortable with using computers. It doesn't solve all of those problems. So, I mean, I think we need to talk a lot more with people like yourself who are heavily involved in this on a day-to-day basis to figure out some of those answers.
Your decision. Your dynamic consent email in another language?
So it can potentially be in any language, yes. So the tool that we're developing for the AGHA, I don't believe it's being translated. Harriet might be able to later on. But potentially embedding it in any system, it could be translated wherever it was put, essentially. So it's not, we don't have a particular package, dynamic consent package that we're offering to AGHA or other projects. It's more an approach that we're describing that researchers can adapt as they see fit.
John, question?
Again, I was interested to hear a little bit about some of the roadblocks you've encountered with human research ethics. Used to be upfront. We looked this earlier. We many years ago came across a lot of hurdles.
So again, I'm really sorry, Harriet, I'm going to throw to you in a moment because of your long experience with Rudy and with other projects embedding dynamic consent. In terms of the AGHA flagships, we're only just crossing that first hurdle now. And in that case, dynamic consent is not being offered as a replacement for written informed consent, but as a bolt-on after. So people are still going through the written informed consent process. So I think ideally down the track, people would be consented straight, for want of a better term, straight into the dynamic consent arm, and that's where the hurdles perhaps might present themselves. But at the moment, it's not replacing the written form, and so it hasn't been particularly problematic for ethics. But Harriet, I don't know if you want to expand on that.
I have a great deal to add to that. The Rudy study has obviously been through the ethics approval process, and the thing they loved about it was that the patients were really heavily involved in how that was all set up in design, and the sort of compelling story related to how it's supporting participants through their research experience is hugely beneficial. The thing that we still haven't quite got our head around is when you need to go back to the ethics approvals committee to review content, because obviously the whole point is it's a live site that changes regularly, and therefore differentiating between the traditional engagement side of things where you don't need approval, so the newsletter style feedback, which can go onto the site, and where you're actually changing the information that helps them decide. That's something that we had to speak with the ethics committee quite carefully to figure out when they wanted updates and when they didn't, which is the only major change. As Megan said, we brought it in iteratively, so there was a traditional process, and then once you agreed, you got your access to your dynamic consent page. That may change depending on how we move in terms of being able to sign electronically and verifying who the patient is and all that sort of stuff. But as a concept, we've been met with support from that committees because it's very patient friendly.
Good. Any other questions?
Hi, I'm just interested in know in the cohort type studies that are going on. What happens when the person is deceased? The consent's going to stop at that, well, it's going to stop in the form of what at that point. Is that already considered in that that's just running around?
That's a good question. It would have come up, I'm very sorry, Harriet. It would have come up, you should have just come up, it would have come up in the CRIS project. We weren't so involved in that one because that lasts over many years.
So the dynamic consent tool can allow that immediately by having a question that allows patients to make those decisions about what they want to happen. That may then be that a family member will take on sort of be able to view and see the information. It totally depends on what the study is, and it totally depends on what's sort of possible in terms of the longer term. But what dynamic consent does allow is to open up that conversation so you can start thinking about those sorts of decisions up front, and then you can again change them over time if you want to. And it's one of the things, so really do have an explicit question related to what happens in the event of death, and they will then make a decision about whether they want to stop being involved or whether they're happy to continue. And other studies may well then have a more involved process in terms of handing over that control to somebody else at various points, not just death, but if you have reduced capacity to make a decision for yourself, all of those questions, you've already potentially got a vehicle to house them.
Good. Any other? Oh, yes.
I just had a question about if you had a, say, tissue bank or a data bank where researchers can apply to access that tissue and data. So somebody goes on and consents yes to those. And what if they change their mind? How do you contact the people who you've sent tissue or data to because as of that date that they've changed their mind? Does that mean that they change it across, or if they've already, that data and tissue has already been given, is that consent considered ongoing? Yes, because they've already got that.
So it depends. Essentially, the answer is it depends. So the system can accommodate those kind of nuances. So people can give advice about whether they want to stop any further research on those tissue and samples, or ideally the system, the consent will travel with the samples and data essentially in an electronic form. I just had another point that has gone out of my head. Sorry. Sorry, I'll come back to you after.
Actually, I can just add to that also for K-Confab after 20 years. Interestingly, we've only had one lady who insisted on withdrawing and us destroying her biological samples and data, which was fine. And we did contact researchers and made them requested that they delete, the data they had on that person. Interestingly, about 10 years later, because we are a failed study, she was then back in and apologised. But interestingly, I mean, as we've been saying, there's sort of a scale of withdrawal. We've also had men and ladies over the age of 80, 85 who've just said, keep everything you have, but I just don't want to be disturbed anymore. I'm elderly and I can't hear on the phone properly, but please keep everything. So I think from a cohort or biobank point of view, as long as you've got that scale of what withdrawal is, we can certainly cope with anyone's requests.
Yeah, and sorry, the point I had been going to add was
that brought up a few questions.
Was that obviously people are generally told that there is a point at which that data can't be withdrawn. If it's already formed part of a published paper, for instance, of course, they can't claw it back. And so that information is given as part of the rest of the information about what happens when, what does withdrawal really mean.
It's also just interesting how you alert those other researchers if you've already sent the tissue that there's been a change and you can give that.
Yeah, so I don't think, I'm not sure the particular examples I've given would do that. Theoretically speaking, it can be electronically coded with the data and samples so that it will flag, the system will flag that withdrawal has happened.
Under good SOPs, every cohort of biobank should know exactly what was given, when, to whom, so that you can, so it's standard operation.
Contact them, yeah.
Maybe one more question before we wonder.
Yeah, hello. I think this is an absolutely fantastic process. I just had two, or one question or one point to make. How many people when you've got different options for consent, in your experience, how many people have actually changed that? So going from a yes to a no to say tissue, or what's been the rate of that? You know, can people flip back and forth constantly? Because I imagine that would be a bit of a problem. And also the second point, when I think was it Harriet talking about participants want to know about what's happening with their samples. Should we be making researchers more accountable in terms of telling us about what research they're actually doing? You know, we do a lot of basic research, but should we actually make researchers, you know, inform the community about what exactly is going on in more detail than what we already do?
Yeah, that's a really good point. And I think, I mean, I would say yes. Generally speaking, you know, researchers are often, if you want to use the public money argument, it's public money, the public should know what's being done with it. But also just from a, you know, people are much more informed than they used to be, are much more interested than they used to be about what happens with their information or with their samples. In terms of your first point, I'm not sure of the rate, but actually the rate of change of mind is very low, and it's not the case of people. We haven't found that it's the case of people flip back and forth or anything. It's people like the option, but in fact they don't exercise the option very often.
Maybe just one more quickly.
Following on from the previous question, or we have patients who are from consent for tissue or from the dynamic platform.
Yeah.
Do they also have to be a face-to-face withdrawal?
So I'm pretty sure that with Rudy they get no, I was going to say they get a phone call, but no, they don't.
It will depend on, it depends on what the research study sets up as its process. Every research study will have a process that allows withdrawal. In this instance, it may well be that the research team will want to make sure that there's no if they can figure out a bit more why it is that that's happened, then perhaps, you know, in some instances, if it's something fairly sort of minor and simple and actually nothing to do with the sample itself, then there may be opportunity to have those conversations. But in this instance, if you turn it off, then that's then reflected. In reality, exactly as Vivian has said, they haven't seen that happen at all. In fact, it's been the other way around, that patients have really appreciated being able to sign up to a small part of the study and then increase their involvement as they get to know the study and they sort of trust the teams more, rather than the other way around. They haven't actually seen anybody withdraw from interventions after that.
And how is there a check in place for the person participating in the study who's withdrawing or participating more? Because it's it's not face to face, and we're doing it at home. There's no real check that the selection of whether they're participating or not. It's actually them and not their family.
Yeah, we've had a lot of discussions around that with verification through really in particular, because the initial conversations are up front. They haven't yet done the sample collection. The sample collection allows for a more involved consent conversation when the sample is taken, so that's another check to make sure that the sample is received. When they then withdraw from that process, it will be potentially followed up when they have another face-to-face meeting or interaction, and until that time it won't be used, because as far as they're concerned, the information they have to not to use it. But that is tricky, and that is something we are going to have to look at much more closely in terms of how to make sure that the person is who they say they are.
But it just, I mean, it touches on, you know, a common problem outside of research in verifying people who are who they say they are when they put in a username and password to any website.
Right, well, on that note, Megan, thank you very much for your presentation today. We thoroughly enjoyed it. Great discussion. So thank you to the audience for your participation. And just a reminder about the upcoming VCCC seminars over the next 2 months. They're also listed on the VCCC homepage. And Megan, thank you very much. We look forward to collaborating with you as time goes on.
Thank you very much.